Good morning, dear friends. I thank you, Dr. Balla, giving this opportunity uh, to speak on the PCD, is a posterior capsule defect, and how to manage these cataracts in adult. So it is an abnormal adhesion of the posterior capsule of the to the polar opacity, pre-existing weakness of the posterior capsule, which predisposes the eye to posterior capsule rupture during cataract surgery. Two types of PCC: stationary, progressive. Classical center opacity with concentric rings around the central plaque, cone-shaped projection in the subcapsular cortex. Progressive become more symptomatic as the peripheral extension of these central plaque enlarge, leading to large PCR, various phenotype classification, grade 1, 2, 3, 4, not going into these details. Intraoperative OCT is important, like type 1 tells us intact PCC. With clearance between PC and opacity, hydrosection can be performed in these cases. Intact PC in periphery, inability to detect in the center, dense opacity, extensive shadowing, and inability to delineate PC.
Slides are
Type
not
2 and
moving.
3 avoid hydrosection.
Slides are not moving. Audio visual, please. Slides are not moving.
Here, can you just check? So it is an abnormal adhesion, just predispose the eye to the posterior capsule rupture during cataract surgery. So intraoperative OCT, avoid hydrosection in type 2, type 3, only hydrodelineation. Clinical presentation usually present early, mean age is 20 to 63 years, increasing glare night, driving difficulty in reading fine prints. Risks of PCR highly variable. Higher in older studies, 26 to 36%, lower in now new studies because of better understanding of surgical technique. Preoperative counseling is very important to these patients. Increased risk of a PCR or nuclear drop and the possibility of retinal intervention, as well as prolonged surgical duration. Often these cataract may be associated with the posterior capsular plaque capsulotomy, which should be explained to the patient. Unilateral PPC, particularly those from childhood, may be associated with amblyopia and therefore visual prognosis may be guarded. So this type of preoperative counseling is very important to the patient before managing. Good capsular access in these cases is very important, 4.5 to 5 millimeter, not too small, not too large. Small may lead later on uh, contraction of the anterior capsule. Hydro procedure in case where clear area is seen between the opacity and the capsule, gentle hydrosection can be, however, avoid hydrosection, only hydrodelineation. Hydrogen inside out technique, slow motion phacoemulsification, low IOP, low vacuum aspiration flow rate. These are the principle of managing these cases. So iris, one of the paper published, the iris spatula guided epinuclear cleavage in posterior polar cataract with the help of without, because that avoid rotation. So is a video presentation of that. So doing good capsular axis, so around 5 millimeter of capsular axis perform, and only hydrodelineation, no hydrodissection. So completing, you see the phaco with the just small break, it was not very hard cataract. You see with the chopper itself, we are expressing the bringing the nucleus in front and then removing without causing any rotation. Again, you see bringing the nucleus. So here we avoid taking out the probe as minimum as possible. And whenever you see we have expressed out, bring the nucleus, epinucleus in the center and remove in the center. So before coming out, inject viscoelastic. and then irrigation, I took a cutter from other side. So the aim is to pull irrigation off, pull in the center and then use a cutter. Now irrigation off, pull the vitreous cortex in the center and use the cutter on. Now cut and remove this cortex so that any vitreous entangle that will also be removed simultaneously. So always keeping irrigation to avoid minimum hydration of the vitreous. So irrigation is separate, keeping away in the anterior chamber, not even going behind. So before coming out, again inject viscoelastic and change the side. So cutting should be off while you are under the anterior capsule, just to avoid damage to the anterior capsule. And we retain the anterior capsule nicely, just cutting on, cutting off. So that is the technique to remove this cortex. So once all of the things are removed, so you see as well as does the vitrectomy and remove this whole of the cortex. And now you can see a large posterior capsule defect. Now before coming out again, we inject viscoelastic, take out this small piece. So now this is 100% cleaning of the things. Now we going after injecting viscoelastic, this is again a DOF lens we put in the sulcus with a optic haptic capture. See, we do minimum rotation of anything, just place in the sulcus and doing optic haptic capture. So that lens is stabilized, doesn't move, and so this surgery is over. Coming to another case, again a posterior polar, typical posterior polar. After doing capsular axis, again the similar way we are removing the nucleus, expressing out, bringing out in the center, and then removing. You see now whole of the, you can see a small defect here in the center, but it is well defined with the thickened margins. So now we are removing, again viscoelastic injected. So this time I am using irrigation aspiration. Irrigation is always away in the anterior chamber. I am not pushing irrigation behind in the capsular bag just to avoid hydration of the vitreous. So changing hand again after injecting viscoelastic, you see whole of the nucleus, epinucleus has been removed, but the defect remained the same, it didn't extend at all. So this time we could place the lens in the bag. This was, so you see this defect is not at all enlarged. So low vacuum, low aspiration, bottle height low. So all these factors, this is how it prevents the further enlargement of this defect. So this was another case which happened after giving intravitreal injection. There was a touch of the posterior capsule. So it was again managed on the similar principles. After doing capsular axis, so finally we are removing the cortex, epinucleus. You see in the end there is a large defect, but we managed so well, and in the end we put the lens in the sulcus. So in this case we just convert the, other option is we can convert the posterior capsular rent into the posterior capsular axis. So after removing everything on the same principles, you see with the help of a small forceps, we are converting the PC into the posterior capsular axis. See, nicely it is done, and doing the anterior vitrectomy. Once this is all done, we can place the lens again in the bag. So IOL is placed in the back, and you can see well-defined posterior capsular axis converted with the help of a forceps. Now in these flax also has its role in posterior polar cataract when it is a hard cataract. So we can just break the nucleus into pieces, and without rotation, again we can remove all the nuclei. Now ultimate complication of this PCD is the nucleus drop. You see this nucleus rotating with PC rent being and nucleus has gone behind. So finally we converted into the 3-port vitrectomy. Whole of the nucleus is, you can see it's lying behind. We were trying to break hard nucleus. Now with the help of a phragmatome, after doing vitrectomy and inducing PVD, we are doing with the help of a phragmatome, again dividing the nucleus into small pieces and eating with the help of a phragmatome. Light pipe acts like a chopper. Between the two hands, we break into the nucleus into small pieces and eating small one by one. You see whole of the nucleus has been removed. And finally, we can put any of the secondary IOL. So summary is a proper clinical slit lamp examination dilated is very, very important. Plan well OCT in cases with doubt. UVM if OCT not possible. Counsel the patient for 3-piece IOL lens. Vitrectomy has to be kept ready. Don't shy to call retina surgeon in case of drop nucleus IOL. Thank you for your kind attention.